Good evening, everyone, and welcome to the December 2024 edition of the Eversight webinar series. Tonight, we will be hearing from Dr. Asim Farouk on the antibody-drug conjugates and the ocular surface. Just a few housekeeping notes. First, this webinar, as of all of our webinars, are recorded and available on demand on our website. Also, please keep an eye on your inboxes for more webinars to come in 2025. All participants will be muted throughout the duration of the webinar, but please do ask questions. You can do so at any point in the presentation by using the Q&A panel, and questions will be answered at the conclusion of the talk. Now on to tonight's presenter. Dr. Asim Farouk is an associate professor of ophthalmology and visual science at the University of Chicago. He received his medical degree from the University of Illinois College of Medicine and stayed in Chicago to complete his ophthalmology residency training at the University of Illinois Eye and Ear Infirmary. He then completed his corneal fellowship at Washington University in St. Louis. We were very lucky to have him come back to Chicago. Dr. Farouk is a highly skilled ophthalmologist providing comprehensive care for a wide range of eye conditions, including cataract surgery, corneal transplantation surgery, and correcting common vision disorders using refractive surgery. Dr. Farouk has particular expertise in diagnosing and treating patients with corneal and external disease, such as cornea infections and ocular herpes. Dr. Farouk's dedication to his patients extends beyond direct patient care and into his research efforts. He continues to study the latest techniques for treating eye disease in order to identify the best management strategies for his patients. Dr. Farouk's research has been published in a number of scientific journals, including Cornea, Investigative Ophthalmology and Visual Science, and JAMA Ophthalmology. So Dr. Farouk, with no further ado, I turn the floor over to you.
Thanks very much, Caitlin, and the folks at Eversight for inviting me to give this talk today. So I'm going to talk about antibody-drug conjugates and the ocular surface. And many of you who are on this webinar may be familiar with this topic because you may be seeing these patients now in your clinic. Here are my financial disclosures. A number of these companies do produce cancer drugs that cause ocular toxicity. So the goals of this talk are to review antibody-drug conjugates as a new class of chemotherapy, including their mechanism of action. I'm going to provide some examples of toxicity associated with ADCs, including slit lamp photos and confocal microscopy. I'm also going to review potential mechanisms of action, including on-target and off-target toxicity from ADCs. And finally, I'm going to summarize and propose future directions. So what is an antibody-drug conjugate? So this is also known as an immunoconjugate, and it represents a relatively new class of chemotherapy drugs. I first saw a patient who was in a clinical trial on an ADC in 2015 when I was in St. Louis for cornea fellowship. Now, an ADC is comprised of a monoclonal antibody that is tethered to a cytotoxic drug via a chemical linker. So these are the three components: monoclonal antibody, cytotoxic drug, chemical linker that connects the two. So the perfect ADC has a monoclonal antibody that is highly selective for a tumor-associated antigen. So that way it'll go right to the tumor cell and bind to it. It also has a linker that cleaves easily at the target, but is stable in the systemic circulation. So you don't want the cytotoxic payload to be to kind of get cleaved off and run into non-tumor cells. You want the linker to keep the monoclonal antibody and the cytotoxic payload together so that the payload is delivered all the way to the tumor cell after binding at the antigen. And then the third characteristic is that it has a highly cytotoxic payload. So the reason that's important is because once the payload is delivered, you want that tumor cell to be destroyed. So these are the three components that comprise a perfect ADC. There's an article in The Lancet published in 2019 that described that ADCs may represent a paradigm shift in cancer treatment because as all of you know, traditional chemotherapies were, for the most part, non-specific. They used to, and some of them still do, target any rapidly replicating cell. That's why, we see hair loss and other complications, GI issues with traditional chemotherapies. But with targeted chemotherapies, and ADCs are just one class of targeted chemotherapeutic agents, the cancer drugs are really meant to go right to the tumor cell and destroy them. So, and around the world, there are more than 100 ADC clinical trials that have either been conducted or are currently underway. So currently in the United States, I think there's somewhere around 12 to 14 ADCs that have been approved. But that number is going to go up. And so we will be seeing patients who are on these drugs, whether or not they have ocular toxicity. So along with this new chemotherapeutic drug class of ADCs, there has emerged a new corneal disease. And a number of corneal findings have been described, but there's one finding in particular that I'm going to go over that's relatively unique, and these have been described as corneal epithelial microcysts. And so this is what these cysts look like. And just to orient you, these are slit lamp photos of the right and left cornea of one of my patients. You can see that these are high magnification slit beam images. And I'd like to draw your attention to the areas surrounding the vertical light beam that's reflecting off the iris. And there's these tiny little dots. And these are the epithelial lesions that we see in association with ADCs. They are pretty difficult to photograph, so you have to do it under high magnification, usually using a slit beam, and either using retroillumination or indirect illumination to get these lesions to show up. But as cornea specialists, we see microcystic corneal edema or other causes of epithelial microcyst lesions. These look kind of like that, but slightly different. But anyway, these are examples of ADCs, and here's a more zoomed in image. Again, these tiny little semi-lucent lesions just confined to the epithelium. So as I mentioned, these lesions show up in the epithelium. Now, they typically are first seen in the periphery. And as patients get additional doses of the chemotherapeutic agent, they may migrate toward the paracentral and central cornea. I will mention one thing, that there are some ADCs in which I've seen that the lesions go toward the center, but then there's almost like a ridge, and they don't pass the ridge. So they go from the periphery toward the mid-periphery, paracentral zone, and the central zone is spared. And I don't completely understand why some of these lesions don't make it to the center for some of these drugs. But one hypothesis that I've shared with some folks is that maybe the epithelial cells that contain these lesions, maybe they die before making it to the center. Now, the good news is that these changes do appear to be reversible with treatment cessation. So if a patient has a bunch of these lesions and it's impacting vision, or they're having other side effects, a lot of times the decision is made in conjunction with the oncologist and the patient to hold the drug. And so this is what I mean by reversibility with treatment cessation. The time course of reversibility, though, is pretty variable. In some cases it may reverse pretty quickly, but in other cases, potentially, based on the drug itself, it may take several weeks or longer for them to completely resolve. So in addition to kind of getting into the visual axis and causing blurred vision, potentially due to light scatter, due to these epithelial lesions, there are also topographic changes that can happen. And this was a single case that was published by Russo, showing topographic changes in a patient on an ADC that was reversible. So there was a period of several weeks after which the refraction actually changed back to baseline because there had been a shift in the refraction while on the ADC. And this is something that, it's a little bit difficult to explain to patients. A lot of times they'll come and they ask, I heard this drug, can cause some vision problems. What kind of vision problems or eye problems can occur? So the microcyst lesions are relatively straightforward to explain. These tiny little dots can show up in the cornea. They can cause some blurred vision, but the change in refraction is interesting because some patients, they may say, well, now I can see far away when I couldn't, or now I can see up close when I couldn't before. So you have to advise them that this is hopefully a temporary shift, and that once the dose is held or the dose is stopped at the end of your treatment, that hopefully you go back down to baseline. When I was seeing patients on ADCs, I was involved in a clinical trial several years ago, and I asked the sponsor if I could get some imaging that was not part of the trial protocol, and they said that was fine. So we have a confocal, and I ended up getting some confocal images because I was really interested to see, what are these lesions? What are these sort of quote unquote microcysts that we're seeing in the cornea? And what I saw was this. And what I felt, and I've shared these images, and these are published in a paper that was published in, I believe, 2020. These show that there are intracellular hyperreflective deposits, and this is basically what we saw throughout different layers of the cornea, especially focused on the areas that correlated with the microcysts or microcyst lesions that we saw using the slit lamp. There were a couple of cysts here and there, but they were not very common. And so that leads me to believe that for the most part, the lesions that we're seeing that look like microcysts are actually, some sort of deposition. There's some sort of hyperreflective material that's located inside these corneal epithelial cells. And so I had a hypothesis that, maybe the drug itself is getting into the epithelium. And I did a little bit of literature review, and actually a group had already worked on this back in 2018. There was a pharmaceutical company that's no longer around. It was called Agensis. And they did some very interesting, actually in vitro as well as in vivo work in an animal model. And the in vitro data was particularly interesting because they showed using fluorescence microscopy that for 3 different ADCs, the drug was actually taken up by the human corneal epithelial cell. So they used the human corneal epithelial cell line, which I use when I worked in the lab when I was a medical student. So this was really interesting and sort of went along with what we were seeing on confocal. So I mentioned some of the changes that can happen, within the epithelium, and what I didn't show pictures of is there can be some increase in dry eye, so increase in fluorescein staining, and I've seen that in a number of patients. There are also some patients that will develop like a whorl-like pattern of staining, sort of like limbo stem cell dysfunction. I would say that the latter is not a majority of ADCs that cause that, but there are some that I have seen cause this sort of whorl-like epitheliopathy. And I think that is something that really needs more investigation. Ashour's group has done some interesting work on ADCs in the cornea. And they did a study that was published a couple of years ago in which they used confocal microscopy to look at the corneal nerves. And so you'll notice, you have a patient 1 at baseline and a patient 1 at week 9. And so that's how, there's a number of patients that they looked at, at baseline and then at some point during the treatment. And what I want you to notice is that there is significant dropout of the corneal nerves. And this is, in a sense, this is actually quite scary because this is showing that the particular drug, these patients were on belantamab mafodotin, which was at the time approved for the treatment of multiple myeloma. Currently, it's no longer on the market, but it might be coming back, showing that there's dropout of corneal nerves. And so this is important, really important that this paper was published, and really important to know because there is a risk if, for example, a patient develops even an abrasion or other things. I mean, this you know the risks of neurotrophic keratopathy. So these patients, we may not have otherwise known that there is such severe nerve dropout. So beyond the cornea, there are other changes that can occur as well. And this is a patient of mine who was being treated for being treated for cervical cancer with a drug called tisotumab vedotin. And these are photographs of the superior palpebral conjunctiva of both eyes. And you can see that there is pretty significant subepithelial fibrosis, greater on the right than on the left. It's on the left side of your image. And this is something that I've seen a handful of times now in patients on this particular drug. I first noticed it on the lower palpebral conjunctiva that there was some subepifibrosis, and so I decided to flip the upper lids as my mentors in residency taught me to do. And so this was, somewhat unexpected because the bulbar conj was actually relatively quiet. And so I think it's important to, flip the lids in these patients just to get a sense of, whether there is ongoing inflammatory damage. And, tisotumab is somewhat unique in the ADCs that are currently approved by the FDA in that it primarily causes a conjunctivitis. And one of the thoughts is that tisotumab targets tissue factor, which is expressed by the vascular endothelium. So the conjunctiva, being a vascular tissue, it may potentially be a manifestation of the drug interacting with the tissue factor expressed in the conjunctival blood vessels. This is another patient of mine who was being treated for cervical cancer with this same drug, tisotumab. And she had started to develop some signs of dry eye and a little bit of SLK. And so I started to treat her aggressively with preservative-free artificial tears and vitamin A ointment. And then I started fluoromethalone, I think once a day or twice a day. And then she came back a week later with this appearance. And I stopped the steroid, I cultured, and a couple of organisms actually grew. Luckily, it responded very quickly to moxifloxacin eye drops. But this was a bilateral culture-positive bacterial conjunctivitis in a patient being treated with tisotumab, who was on a pretty low dose of topical steroid for a relatively short period of time. So with this particular drug, again, I think it's a little bit different from some of the other ADCs, which primarily cause corneal problems. But I'm a little bit more cautious now, or quite a bit more cautious actually now, in using any form of long-term steroids in patients on this particular drug. This is a patient of Dr. Tauber in Missouri that developed bilateral corneal ulcers. And this was a very severe case of toxicity that required, procedural intervention. This patient actually, he did bilateral bright mem allografts in both eyes. Patient actually ultimately did okay, but this was a really, really severe case of ocular toxicity. So this is just an example of the fact that we need to be very, very vigilant in how we treat these patients and how closely they need to be monitored. Patients who are on mirvetuximab, which is a drug that is used to treat ovarian cancer, I have also seen microcysts, but with this particular drug, I've seen there's a whorl-like epitheliopathy, sort of this signs of limbal stem cell dysfunction in a number of patients. And some colleagues I've talked to around the country have also noticed with this particular drug sort of a higher incidence as compared to some other ADCs of limbal stem cell dysfunction. So in these patients, actually, both myself and colleagues I've talked to, we have used steroids a little bit more liberally, and so far haven't run into any issues. But again, have to be cautious, especially if, for example, there is an impact on the corneal nerves, as we saw in the case from patients who are on belantamab mafodotin. So I know I quickly went over sort of a few different manifestations of ocular toxicity, but I wanted to touch on potential mechanism, because with ADCs, there are some ways to kind of understand why it is that the cornea may be targeted, or the ocular surface for that matter. So side effects or toxicity from ADCs may be hematologic, hepatic, neurologic, and ocular is in most cases, or in many cases, the most common form of toxicity. Now, toxicity from ADCs can be divided into on-target or off-target toxicity. On-target toxicity means that there's a cytotoxic effect on a non-cancer cell that expresses the target antigen. So in these cases, the mechanism of action or the mechanism of toxicity may be related to, or might be the same as, the effect on the cancer cell. So, cancer cells express a certain antigen. That antigen is targeted with an antibody-drug conjugate, but other normal cells might also express that antigen, maybe not to the same extent. The concentration is lower, but those cells may be susceptible to the toxicity. So this is called on-target toxicity. By contrast, off-target toxicity is where there's a cytotoxic effect on a non-cancer cell that does not express the target antigen, or there's minimal expression. And there are a few potential mechanisms of off-target toxicity that have been described. For a particular agent, how can we tell whether there is on-target or off-target toxicity? Well, it might depend on the drug. So I gave an example earlier of tisotumab, in which tissue factor is expressed by the vascular endothelium. Well, there are some drugs that express HER2. So HER2, as you may know, is expressed by certain kinds of breast cancer. Well, the corneal epithelium also expresses HER2. And so a HER2 targeting drug could cause toxicity, theoretically, in the cornea by an on-target pathway. But this doesn't mean that there may not be an off-target pathway in addition to the on-target mechanism. But for some ADCs, they target antigens that are not expressed in the eye, but they still cause toxicity. And so this may represent off-target toxicity. Now, there is some evidence that macropinocytosis, so I'm taking you all back to medical school. So macropinocytosis, if you recall, is a form of non-specific cellular uptake, also known as cell drinking. It's one of the ways that cells sample the environment around them, and actually they can take in nutrients from the surrounding environment. So there is some evidence that macropinocytosis may be implicated as a form of toxicity, as a cause of toxicity for some ADCs. And in fact, that same group that I mentioned earlier that did the in vitro studies, that company Agensis, which is no longer around, they found that inhibition of macropinocytosis actually caused delayed and reduced cellular uptake of the drug, both in vitro and in vivo. And they thought of sort of attempting the inhibition of macropinocytosis because of what they saw with the in vitro uptake of the drug. It looked like macropinocytosis on in vivo fluorescence microscopy. And so it's possible that some of the ADCs that, that are currently on the market may cause off-target toxicity in the corneal epithelium via a form of non-specific cellular uptake, such as macropinocytosis. So I kind of wanted to learn when I came across this information in the literature and based on the, some of the signs I was seeing in my patients, how do you inhibit macropinocytosis? If one were to try to block this process, what could you do? So one way is to actually modify the drug, and this is what Agensis did in that study. They actually modified the composition of the drug to make it less likely to undergo macropinocytosis. It has to do with the charge on the drug molecule itself. But unfortunately, for drugs that are already FDA approved, they're already on the market, it's relatively unlikely that the drug manufacturer is going to go back and change the drug or be able to do that at this point. So I wanted to see if there was a way to block macropinocytosis with the use of a therapeutic agent. So it does turn out that there was a study done that was published in the British Journal of Pharmacology in 2018 that looked at 640 currently FDA-approved drugs and found that 14 of them actually inhibit macropinocytosis. And so this was not done with the goal of inhibiting macropinocytosis in patients who are on ADCs. It was just a completely separate study in which they sought to find drugs that inhibited this process. They found that 3 of these had sort of favorable inhibition or significant enough inhibition of macropinocytosis, but they had the least cytotoxic effects. And these were imipramine, phenoxybenzamine, and vinblastine. There's one other agent that I'll add in here, which is H1 blockers. H1 blockers were also found to inhibit macropinocytosis. And so these sort of antihistamine drugs are available over the counter. So there are some sponsors that are looking into the potential role of antihistamines in potentially preventing macropinocytosis as a cause of ocular surface toxicity from ADCs. About a year or so ago, I was approached by someone who's a breast cancer specialist at UCSF, as well as a cornea specialist who's named Neil Pasricha, who's a collaborator of mine now. And she suggested that we develop an ocular toxicity working group based on the fact that those of us who have been involved in taking care of these patients for over the last several years and have been involved in some clinical trials and as yet have not been able to really figure out how to best manage these types of toxicity, or at least prevent them, to develop a working group. And so we have collected or sort of assembled a number of ophthalmologists as well as oncologists from across the country representing the institutions that you see here. And our goal is really to try to come up with ways to address this problem, because as I mentioned in the beginning of my talk, there are over 100 trials that are either completed or currently underway in this drug class. And so we are going to be seeing more of these patients. And the fact that these toxicities are developing, we don't yet have a way to prevent them or adequately treat them. It needs to be a concerted effort on the part of people who are interested in working on this topic. And our first task that we identified was to develop an ocular toxicity grading scale that is or will be hopefully a consensus among the members of the working group. And so we are in the midst of hopefully finalizing that scale in the coming weeks and submitting that for publication. So stay tuned. Hopefully you'll hear about this ocular toxicity grading scale from the consensus group in the near future, hopefully early 2025. All right, so to summarize, ADCs comprise a new class of chemotherapy drugs. This is one example of a broader category, which is targeted cancer drugs. A number of ocular surface and corneal changes have been observed. I described to you microcysts, or what I call pseudomicrocysts, signs of a worsening dry eye. There are corneal topographic changes, limbal stem cell dysfunction, and there are other things as well, but those are some of the major things that we've seen. And then with tisotumab, we talked about conjunctivitis and also subepithelial fibrosis. The mechanism of ocular toxicity may depend on the specific ADC as to whether it's on target or off target, or it may be a combination of both of those pathways if the target antigen is present in the eye. And then a consensus grading scale for ocular toxicity is hopefully coming soon. All right, so here are my references. I want to thank all of you for your attention, and thanks again to Eversight for the invitation to speak, and I'll be happy to take any questions at this time.
That was great, Dr. Frug. Thank you. We'll give folks a couple minutes if they want to type in those questions. This has been very interesting, obviously a little different than what the eye bank is used to when it comes to the transplantation field, but really fascinating to hear from. And I think that consensus scale will really be a great tool. What is your estimate time frame that will be ready by?
It's a good question, Caitlin. You know, I feel like I've been talking about this scale now to people for the last several months. You know, I think it's a good thing actually that it's taken so long. You know, we've been working on this for the better part of a year, and part of it is that there are just so many people who are part of this working group, and getting everybody's input and consolidating it and really trying to fine-tune the scale has taken some time. So we are at a sort of a pre-final version of the scale, and I think you know, Neil and some of his colleagues at UCSF and I will hopefully be able to, and other folks as well who are working on this behind the scenes, will hopefully get a draft out to all the members of the working group for a final review. So sometime in the coming weeks or next couple of months, I would say, but I almost hesitate to give too tight of a timeline on it.
Oh yeah, no, that's great. We do have one question. So other than aggravating dry eye, antihistamines are usually well tolerated. Have you tried using these in any of your patients based on those initial reports to see if they helped at all?
Yeah, great question. I have used topical antihistamine. You know, we used to have a preservative-free topical antihistamine on the market, and I believe it's no longer available. So unfortunately, that option that I used in the past is no longer around. I've been a little bit reluctant to use preserved drops in these patients just because I think their ocular surface is already a little bit compromised. But it's a little bit hard for me to know if the antihistamines helped. You know, the situations in which I've used them are patients who have had a certain degree of ocular surface toxicity in which the chemotherapy was held, and I had them on preserve-free tears, maybe some mild, a little bit of steroid drop, like a fluoromethalone once a day. And then I added on, the antihistamine drop, once or twice a day. So those patients did get better, but I don't know if it was because of the antihistamine or because of the other things or because of stopping the drug, which honestly is probably the biggest factor.
It's great. Thank you. We'll give folks another minute to type in those questions. Sometimes that takes a minute. But I do, while we just finished to wrap up, Dr. Farouk, I want to thank you again for sharing your expertise with us and for everyone for logging in this evening. I think coming back after our holiday, we're all catching up a little bit. So we appreciate everyone taking their time. And I'll give a last call for any questions while we wait for those to come in, Dr. Farouk. Any final thoughts or words you'd like to share?
Yeah, it does look like there's one more question here.
Oh.
It says, how long are you recommending holding the drugs, temporary break or permanently? Yeah, that's another great question. So it really depends on a couple of things. So one is if the patient is in a clinical trial, there will be a specified protocol usually for when the drug is held and what the parameters are for that. I will say, however, that the recommendation for holding the drug is not really, at least I don't view it as my decision. I think that this is a decision that should be made by the oncologist and the patient. Our job as ophthalmologists, I think, is to identify when there's a toxicity, grade it according to whatever scale we are asked to use. Once the consensus scale comes out, that might be useful for this. But in a clinical trial setting, for example, there will be a scale that will be used by the oncologist and in discussion with the patient to follow the parameters of the trial. Even outside the trial setting, I would say that the oncologist is really the one who's best suited because while we are the experts of the eye, I don't really want to be the one to make a decision on whether a drug should be held because I don't really know what the impact of that will be on their cancer. And at least at this stage, these drugs are really being used on patients who have failed other chemotherapy regimens. So in some cases, this may be their last option. There are some sort of grade, based on the grade of toxicity, there are some types of toxicity for which discontinuation is recommended. And this, if those of you who get involved in clinical trials, you'll see that as part of the guidance that's provided in the trial. And even for some of the FDA-approved drugs, there will be or there may be some guidance that is sort of in alignment with the fact that if there's a severe toxicity, then there should be serious consideration to discontinue the drug. I would say that at least from an eye perspective, any type of toxicity that causes, permanent structural damage to the eye that puts, vision at risk, that's not a reversible change, that is sort of something that could be considered for discontinuation of the drug. But again, I would say that as ophthalmologists, I wouldn't recommend for us to be the ones to decide that. I think the oncologists are sort of better equipped to see the big picture in terms of the cancer treatment. We can certainly make our recommendation, but we're not the ones who are dosing the chemotherapy.
There was another comment, Dr. Farouk. Someone just thanked you for sharing your work and your insights.
Oh, well, once again, thank you for having me, and thanks to Eversight for the invitation to speak on this topic. I'm happy to answer, any questions offline as well. If it's helpful, Caitlin, those who attended this webinar, if you want to share my email, I'd be happy to share it. There's not that many people who have seen a lot of these. I'm certainly, there are folks out there who have seen a lot more than me as well. But as these drugs become more common, I think that we are all going to have to kind of work together and help each other to navigate some of these toxicities that show up.
Absolutely, and I'd be happy to share your email for all those who attended tonight. Once again, Dr. Frug, thank you, and thank you all this evening. There will be a brief survey following the webinar if you guys want to keep your eye out for that, as well as for future emails about webinars in 2025. So thank you again, and I hope everyone has a great night.
Thanks, everybody.